The System of Care Academy is celebrating its 10th anniversary with the theme Celebrating Our System of Care, Past, Present, and Future. This year, the Department for Behavioral Health, Developmental, and Intellectual Disabilities partnered with Mental Health America of Kentucky to offer 10 sessions from national and state leaders covering a host of topics related to trauma and healing, Kentucky's response to crisis in human trafficking, weight stigma, and substance use treatment. The system of care approach was first introduced nationally in the mid-1980s in response to documented difficulties serving children and youth with the most severe mental health issues and their families. Kentucky's implementation has matched the federal evolutions and initiated its work in 1989 with a pilot of initial implementation of Kentucky Impact, using system of care core values and guiding principles. Kentucky has received 6 federal system of care grants since 1998. And the System of Care Academy originated in 2014 through Kentucky's 4th System of Care grant, which served as an umbrella for children's behavioral health redesign, connecting promising innovations across agencies. Each year, the Department for Behavioral Health, Developmental, and Intellectual Disabilities convenes the System of Care Academy to strengthen Kentucky's system of care for children, transition-age youth, and their families. Since 2014, the Academy has prioritized themes such as promoting equity, reducing health disparities, collaboration among interstate and community partners, prevention, early intervention and treatment, building resilient youth, families, and communities in Kentucky's response to the opioid crisis. 2024 presents us with priority areas such as youth mental health, including youth with high acuity needs, crisis care, and substance use prevention, and I hope you see the work in progress and opportunities for growth to better serve our children, youth, and families. Kentucky has worked hard to boost access to treatment while also reducing stigma around asking for help. Kentucky implemented the 988 crisis line and launched Find Help Now. In 2022, Kentucky saw the first reduction in overdose deaths in 2018, one of only 8 states to record a decrease. Kentucky increased access to services by covering telehealth services. And we have seen increases in peer support services and agencies incorporating youth and family stakeholders, including compensating them for their time and lived expertise. As the Academy draws to a close, I want to personally thank each of you for taking the time to join us at these events. I challenge you to share what you've learned with your colleagues and community, listen without judgment to children and families, empower them to be active participants in their own behavioral health journey, and translate your learning into action.
Okay, and now I'm going to turn it over to my colleague, Kate Overberg-Wagner, to introduce our presenter.
Thank you, Lee. I'm Kate Overberg-Wagner. I work with Lee Taylor in the Kentucky Division of Mental Health and have helped her with the Kentucky System of Care Academy. And it is my pleasure to introduce Dr. Mark Fishman, who's an addiction psychiatrist and leads the Maryland Treatment Centers, a regional behavioral health care provider, which offers programs for residential and outpatient SUD and co-occurring treatment for youth and adults. He is a member of the psychiatry faculty at Johns Hopkins University School of Medicine. His academic and research work has focused on addiction pharmacotherapy, models of care for youth, particularly with OUD, and treatment placement and matching strategies. Dr. Fishman served as co-editor for past editions of the ASAM criteria for the treatment of substance-related disorders. He served as a past president of the Maryland Society of Addiction Medicine. With that, I will turn it back over to Dr. Fishman.
Great. Well, thanks so much for that. And it's a pleasure to be here with you guys. And I'm going to talk today about one of my favorite topics, which is improving the quality of care for youth, or as they say in Brooklyn, New York, youths. And just a word about that. Throughout the day, I'll be talking about the term youth as encompassing both adolescents, teenagers under 18 and the like, and young adults, you know, up into their mid-20s, because as you guys know, if you do this work, there's no bright line and chronological full cutoff for being a young person. It's not that people are all grown up at age 18 in one day, right? It's more a developmental continuum of maturation or immaturity, and we're concerned with the particular needs of young people who, you know, as you know, are not just short adults, but we think about that as a continuum. And I'm going to be specifically talking about young people with opioid use and opioid use disorder. And as we go through the day, I know there's probably a range of experience and perhaps a range of knowledge about opioid addiction and the medications for opioid addiction. So as I talk about things, I'll start with a very brief overview of the basics, a little bit of a 101, and my apologies if that's stuff you already know and if it's too simple, but I just wanted to make sure that we cover some of that. I'll start just with my disclosures. And the important thing is that I've worked with some of the pharmaceutical companies that make some of the medicines that treat opioid use disorder that I'll be talking about today. I don't think that biases me, but you've got to be the judge, so let me know. And here's what we'll be talking about, the outline of our conversation today. Start with the bad news, the scope of the problem, patterns of use, who's doing what, looking at the bit of the clinical picture, as I say, an overview of what are opioids and what is opioid addiction and what differentiates it in such a special way from other substance use disorders. We'll spend most of our time talking about treatment and with an emphasis on the medications that we use for OUD. And those of you who are experienced in that will know that that's standard of care across the lifespan, certainly for adults. We think of medications for opioid use disorder and the 3 FDA-approved medications that I'm sure you know about, methadone, buprenorphine, naltrexone, are life-saving and prevent relapse and are our first-line treatment for adults. But one of the things that many people may not know is, well, what does that mean for young people? What does that mean for adolescents and young adults? And how do we translate the well-known body of knowledge about the treatment of older adults with OUD, with medications, to a younger cohort with developmentally specific approaches? We'll talk a little bit about that. We'll talk about one of my favorite topics, an emphasis on involving families, which you'll hear me say I think is underdone in our field. Talk about some innovative approaches, and then if we can have some time to talk about next steps and what the implications are for building better systems of care. And then, of course, as you guys want to ask questions and make comments along the way, that'd be great. So here's kind of a summary of the entire conversation. And if you get nothing else, this is what I want you to get. You know, we understand that OUD is an advanced malignant form of substance use disorder writ large. And like most substance use disorders, it usually begins in youth. As you may know about substance use disorder / addiction in general, although there's plenty of people later in life that have problems with addiction, when did it begin, right? 90+% of adults with substance use problems initiated those problems before the age of 18. And substance use disorder, I think of as a developmental problem of pediatric origin. That is, it has its onset in the second decade of life, in the mid-teen years, and the peak prevalence of all substance use is at the end of the second decade of life and the beginning of the third decade of life. So that's why we're so interested in young people, both from a prevention point of view and from a treatment point of view. And like all major remitting, relapsing chronic illnesses, the earlier we intervene, right, the more difference we can make in altering the trajectory. That goes for OUD like anything else. Adolescents and young adults are extremely vulnerable, and that vulnerability is probably what leads them to have these very high rates. Young adults, in particular, are disproportionately affected by the current opioid crisis. And there is plenty of good evidence and expert clinical consensus that the medicines, MOUD or MAT, for the treatment of OUD that we know about in adults are first line, are effective, should be used as standard of care in youth. But unfortunately, not everybody's gotten that memo, and dissemination is poor. There's problems with capacity, not enough providers and programs, misinformation about whether we should be using these medicines in youth, which we should, and you'll hear me repeat that again and again, and problems with prejudice about the medicines. Is it real recovery, et cetera? And by the way, which it of course is. We think that broader use of MOUD is a vital step as a cornerstone in improving treatment, and medication forward approaches are especially important as part of a holistic, comprehensive, multi-component, integrated approach, but oftentimes it's important to start with medicines. Unfortunately, youth have worse outcomes than mature adults, than older adults, and that's the same issues of developmental vulnerability and treatment system limitations that probably get them into trouble in the first place. And then we'll talk about some strategies that target treatment capacity, engagement, and retention. In particular, I'm interested in family involvement. I'll show you a little bit about an intervention my group has been working on for the past decade or so. We call it the Youth Opioid Recovery Support Intervention, but there are others as well. And the key issue is to respond in a developmentally informed, developmentally specific way to improve outcomes for adolescents and young adults. All right, so some of the bad news. You guys have seen this slide, I'm sure, a gazillion times. It's a reflection of the opioid overdose death crisis in this country, reflecting the various waves of the opioid crisis over the past, 3 decades. And at first, we saw a rise in deaths from prescription opioids here in the blue, and then an uptick in deaths from heroin here in the darker blue. But this catastrophic, alarming, steep increase that you see in the last, 5-10 years is due to the synthetic illicit opioid fentanyl that you guys know all too well, taking off in 2015 or so. And we've had a little bit of maybe good news in the past year, that we've seen a little data that shows a flattening and maybe even an increase in the past year or two. I was pleased to hear in the introductory remarks by your commissioner that Kentucky has been a leader in that reduction. But unfortunately, overall, the news ain't so good, right? The curve is steep. We've cleared the horrific milestone of 100,000 American deaths. And it looks grim, and we aren't winning. And that's why we're talking about this. How do we do better? Now, that's mostly adults in this data. This is people of all ages, but let's look a little bit at young people. This is adolescents. And although adolescents represent a very small minority in absolute numbers in terms of the opioid overdose deaths that we're experiencing in this crisis, thank goodness, the increase that you see here in the fentanyl era is steep and alarming, as it is in adults. And the proportionate increase in adolescent overdose deaths in the last few years has actually been higher than the proportionate increase in other age groups. I can't tell you why that is, and thank goodness it's still low in absolute numbers, but that's very alarming that it's increasing, and that seems to be a national phenomenon. This is a little bit older data, and the gap is closing, but I wanted you to see this epidemiology, that young adults have been disproportionately affected by this crisis. Now, that gap is narrowing, as you'll see that the line for young adults is trending downwards and converging with the prescription drug use rates for the rest of the population. But historically, it has been a significant and disproportionately large problem in young adults. And the same is true here as you see in heroin. The absolute numbers are lower for heroin than they were in the height of the for prescription opioids in the height of the prescription opioid crisis. And the gap is narrowing. We don't really have this kind of age breakout data in the last few years for fentanyl, so stay tuned for that. But again, disproportionate historical representation by young adults, another reason why we have to focus on developmentally informed approaches. So a quick overview for those of you who are kind of new to the area of opioid addiction. You know, what are opioids? They are historically substances, chemicals derived from the plant called the opium poppy. That's been around for thousands and thousands of years for both medicinal and intoxicating use. Modern synthetic chemistry has created synthetic versions. And so they all act on the brain's built-in opioid system. God gave us opioid receptors and built-in opioid-like substances, enkephalins, endorphins, et cetera. We use that in our brains and throughout for signaling for pain relief, for psychological relief, for reward and reinforcement in small, nuanced, little balanced amounts, the way all neurotransmitters operate. But that system, like with other substances, hijacked by very powerful street substances, which hijack that system. We still use opioids for pain relief medically. And of course, the overprescription by ill-advised doctors during the height of the prescription opioid crisis was what led to fueling a great deal of the problem and led people past prescription opioids to heroin and fentanyl. Largely, that particular avenue of initiation of opioid addiction has subsided considerably, not to zero, but considerably, as we've trained doctors and other prescribers about the more judicious use of opioid analgesics. You'll recognize some of the names, famous brand, famous subcategory here, oxycodone, which was originally branded as Percocet, but the other names, codeine, morphine, and heroin and fentanyl as being particularly relevant to the modern street crisis. And people use it in a variety of ways. You can swallow the pills, you can crush them and sniff them, you can sniff the powder, you can smoke the powder, and of course, in its most severe form, injection of heroin, injection of fentanyl. Just a quick Biology 101 refresher. Remember what I said about built-in opioid receptors and the hijacking by street opioids. This is a cartoon that shows an opioid fitting hand in glove, like neurotransmitters do, into an opioid receptor on this brain cell or neuron. And then this neuron tells this neuron, oh, I'm turned on because my opioid receptor is activated. And in the reward reinforcement cascade, this cell tells this cell to turn on, and then this cell releases another neurotransmitter, dopamine, which of course you've heard of, which is one of the main transmitters of all the reinforcement of the known substances of misuse. And that dopamine comes and sits on the dopamine receptor here at a third neuron saying, ah, do more of that, right? And that's what dopamine does for us. It reinforces behavior. As there are dopamine surges, we are provoked and stimulated to be reinforced in a signal to want more of whatever got us more dopamine. And opioids are certainly one of the things that do that pretty efficiently, unfortunately. The subjective effects of opioids include intoxication, euphoria, but also sleepiness and stress relief. People describe a sense of peace or bliss. Some people contrast it with the more activating, stimulant-like substances of addiction, like cocaine and methamphetamine, which are more energizing, whereas opioids are more slowing down and peace-inducing. But either way, people initially quite enjoy them. Of course, the course of addiction is that in phases, euphoria and pleasure, or positive reinforcement, is more prominent early in the course of the disorder, and negative reinforcement or relief is more prominent later in the course of the disorder, where I'm sure you've heard people say, I don't even like it that much anymore. I'm not even getting high. I'm just trying to feel normal. I'm just trying to get well. I'm just trying to get relief. It's always a bit of a mix, but it is interesting, that biphasic approach. There are the medicinal effects we've talked about, and then there's a variety of standard side effects. Make you sleepy, make you not think so well, give you constipation, make you itchy, and in a medically relevant way, in an overdose, reduces the drive for breathing or causes respiratory depression, and that's what kills people if they take too much. Fentanyl is at the core of what is the standard street opioid these days. It varies in terms of its penetration of the street supply throughout the country and varies regionally. Where I am in Baltimore, it's all there is on the streets. There is essentially no more heroin, and anybody that sells you heroin is really selling you fentanyl, and there is no more Percocet, and anybody that's selling you Percocet is really selling you fentanyl. In other places, it's still a mix, but it is the predominant driver of the current phase of the crisis, and certainly of the overdose deaths. And the reason is because it's what's on the street, and it's these days manufactured in illicit labs, mostly in Mexico, with precursor chemicals imported from China. And one of the reasons the gangsters and smugglers like it is because it's so potent, 50 to 100 times stronger even than heroin, which is already 50 times stronger than morphine. You can move large amounts of very potent drug in smaller volumes, so it's easier to smuggle, easier to reconstitute at higher profits. So, that's what the gangsters are doing. But that very high potency also makes it that much more treacherous because there's little margin for error in terms of dosing. So even an experienced user can easily make a dose miscalculation, not understand the potency of the particular supply, take a little extra, and it only takes a little, and therefore fatalities are tragically common, mostly unintentional, where people are trying to push the boundary of maximizing intoxication, but cause respiratory depression. The thing that's super important to know is that there is also a phenomenon of unintentional use of fentanyl. Surely plenty of long-standing opioid addicts know they're getting fentanyl, intend to get fentanyl, and understand the risks, and still make dosing errors. But there's another group of folks who are taking fentanyl not knowing they're taking fentanyl, because fentanyl increasingly contaminates the drug supply of what is not labeled or widely known as opioids. So, or not widely known as fentanyl. For example, it might be in the cocaine supply. It is increasingly in the methamphetamine supply. It is in counterfeit pressed pills labeled as Percocet or Xanax or Adderall. And I'll show you some pictures in a minute. And as I said, in my community, anything you buy on the street that's called Percocet is only fentanyl, nothing but fentanyl. That may vary in a variety of places. There's also reports of it contaminating the cannabis supply, although that's rarer, and I think the media has exaggerated that a bit, but it certainly does exist. And I just want to show you some pictures. Particularly, well, here's an example of equivalent amounts of potency. Here's this much heroin equals this much fentanyl. Look how small that is. And there's another fentanyl analog called carfentanil, which that's just one little grain. It magnifies the potency another 10 to 50 fold. But take a look at, in this bottom right-hand corner, these Perc 30s. I don't have a picture here of the real manufactured Percocet oxycodone product, but you can't tell the difference without a microscope. They have sophisticated pill presses. It looks just like the real thing. The dealers are saying it's Percocet, and some people know it's fentanyl, but a lot of people don't. And obviously the risks are much exaggerated. Are very much greater with fentanyl than they would be with oxycodone. Some features of opioid use disorder that are important to understand in terms of clinical implications. Compared to some other substances, the development of tolerance and other aspects of physiological dependence and other aspects of disorder and addiction are more rapid, perhaps, than other substances. From initiation to getting fully hooked, to having it totally overwhelm your life. That duration tends to be shorter with opioids than, for example, alcohol, cannabis, even methamphetamine. There are a wide range of severities among all users of all substances. Some people casual users, some people light users, some people mild disorder, some people severe disorder. But that is less common in opioid use disorder. Surely there are still some people who are casual users. There are some people who have mild disorder, but it tends to congregate or magnify at the higher severity end of the spectrum compared to, say, alcohol or cannabis. And relapse rates, although they're high in all substances, are especially high with opioid use disorder, especially when medications are not used as part of the tool chest for treatment. So let's talk a little bit about treatment. Withdrawal management is not the most important part necessarily of treatment. And as I'll tell you, it doesn't lead to sustained remission, but it might be necessary if not sufficient. And that's because withdrawal is such a severe part of the experience, the clinical phenomena of opioid addiction. Most substances, maybe all substances of intoxication we know, have some degree of withdrawal, but in opioids, they're particularly severe. Alcohol perhaps is the worst, and it can be fatal. Opioid addiction is not fatal, although the patients will say they feel like they're going to die. But just because it's not fatal, it doesn't mean that it isn't very impactful. It's miserable. People hate life when it's happening, and it's very motivating to continue using to prevent withdrawal. So you get severe symptoms when you stop. The biological phenomena is a result of adaptation to the physiological dependence. All these symptoms that you know about, anxiety, stress, chills, nausea, vomiting, diarrhea, body aches, bone-crushing pain. These symptoms are just the same in youth as they are in older adults. With heroin, we were used to a clinical phenomena of withdrawing lasting 3 to 7 days and peaking at 2 to 3 days after stopping. Fentanyl becomes a long-acting drug with chronic use. It's stored in fat tissues in the body and leaches out slowly. And so the withdrawal period is longer with fentanyl than for heroin, and the peak is later. So the really intense misery doesn't just last 2 to 3 days to peak. It can go 4 to 6 days to peak, sometimes even longer. And you will see fentanyl in the urine drug test sometimes as much as 3 weeks after last ingestion. And as I said, it's a major trigger for continued use. All right, so that's the kind of simple clinical overview that we got through quickly. Now let's move to treatment. Before we get to treatment, I want to put in a plug for prevention. That's not the main topic for today, but it's really important. And as we know from public health for hundreds of years, you can't just treat your way out of an epidemic. Treatment is key. It's one of the pillars, but in order to solve an epidemic, you also got to limit the pipeline of new cases. You've got to prevent cases. So how is that relevant for youth OUD and youth SUD? Well, remember, I said, and I like this tagline, you tell me if you like it, that addiction is a developmental disorder of pediatric onset. And I want us to think of OUD not as a separate disorder, but as part of the arc or continuum of SUD writ large, remember, with initiation in youth. The vast majority of young people who come to have a problem with opioids, who come to initiate opioids, not 100%, but pretty high, have had problems with other substances first, have had loss of control and disorder with other substances. And for youth, what are those substances? Nicotine, alcohol, cannabis. And we know that earlier onset is associated with worse outcomes. We know that earlier intervention is associated with better outcomes. So we want to see opioid addiction not just as its own phenomena beginning the first day somebody ever initiated or experimented with an opioid. We want to think of it as having its antecedent roots in pre-opioid, if you will, substances, where the opioid phase of the illness is an advanced malignant stage in the progression of the continuum of the illness. And that conceptualization, I think, leads us to the conclusion that intervening early in adolescence for their non-opioid substance use and substance use disorder prior to opioid initiation, again, that's cannabis, alcohol, nicotine, is in itself OUD prevention, is in itself OD prevention. And I think that message needs to be rung from the hilltops, because lots of people, again, another topic for another day, lots of people are all too willing to say, oh, you know, they'll use cigarettes, they'll drink beers, they'll smoke cannabis, and what's the big deal? That's just teen hijinks. Well, for a subpopulation, there is progression to OUD, and so there's a big prevention message there. We shouldn't just wave it away. We need to treat that as a serious, serious public health issue. Here are some of the components. We talked about withdrawal management. We're going to talk about some of these other components. And just a minute on withdrawal. Again, it's not the cornerstone of treatment, but it's often where treatment has to start because, as I said, people who are experiencing withdrawal will be highly motivated to stop because they want to relieve their withdrawal. So what is it we typically do? It's the same as what we do with older adults. We give them a buprenorphine taper, any opioid taper with any opioid substance will do. Buprenorphine is the one that's mostly used these days in modern treatment settings. It's easy, it's safe. We add other ancillary comfort medications. You've heard of clonidine. We use ibuprofen, Motrin. We use sleep aids. We use medicines for cramps and diarrhea. The list goes on. And people are miserable. There's no reason to limit the amount of medicine. We should give them the comfort they deserve to get through this. The old-fashioned idea that if they suffer, that'll learn them, and now they won't do this again because they won't want to be sick, that's nonsense. People should get a lot of medicines to make them feel comfortable as a way of engaging them in treatment. So if they're comfortable, they'll stick around and move on to this next phase of treatment. Detox, or, you know, as we say now, withdrawal management, but either term is fine and you all know what we mean, is never a successful strategy on its own. People who detox without moving on to other treatment phases, including MOUD, mostly relapse. Enduring MOUD has to be the rule. So what are the MOUDs? By the way, the terminology shifts. MOUD, as you know, stands for medication for opioid use disorder. We've historically used the term MAT, medication-assisted treatment. We now use the term MAT to mean medications for addiction treatment. I don't care what you call it. We all know what we mean. And the three FDA-approved medicines are buprenorphine, which is available in a daily under-the-tongue pill or strip. It's also available in a monthly extended release injection, and there are 2 brands commercially available. There's naltrexone, which is used in a monthly extended release injection, and there is methadone. And they are all very good medicines. The historical evolution of biological advance has gotten us to have these 3 medicines. I'm looking forward to the day when we'll have more, but it's great to have these tools in the tool chest. And you may know that we're lucky enough that these are very effective. And unfortunately, in other specific substances, methamphetamine, cocaine, cannabis, alcohol, we may have some medicines, but they're not as effective. We haven't advanced our biological drug discovery to the level of sophistication that we have with these medicines. So thankful for that. They are all good. I joke, which is better? The answer is yes. It's less about which one is better in a horse race. It's which one is better for whom on what day of the week. And we're still figuring that out. But the main point is that all patients with OUD should be offered and encouraged to be on MOUD. And I want to now move to trying to convince folks why that is, and especially why that is for young people. So I'm not going to show you a ton of the research, but I just want to give you a snapshot. Again, I make the point that it's standard of care for everyone. And the broad brushstrokes, and this is more adult data, we don't have as much data for young people, but the broad brushstrokes of the data is that the rates of relapse post-detox from OUD are enormous. 80 to 90% of patients post-detox have dropped out and relapsed a month later. That's terrible. If you add MOUD to the mix, if you transition people to enduring or maintenance MOUD with one of those three medicines, and the success rates are roughly equivalent, give or take, you get enormous improvement. That is, you get down to 50% dropout and relapse out at 6 months. It's not perfect, certainly room for improvement, and I'm going to be talking today about that room for improvement, especially in young people, but it sure beats the alternative of no medicines, and that's why we are such strong advocates of using medication. Now, again, not everybody's gotten this memo. There is problems with capacity, there's problems with disinformation, there's problems with dissemination, there's problems with prejudice, and these are some of the things I'm sure everybody's heard. So one of the things we have to do as treatment providers or policymakers or advocates is myth busting. People say, oh, it's trading one addiction for another. Well, no. Look at the list of the criteria for an addiction, right? Sure, at least for two of these medicines, buprenorphine and methadone, you can have withdrawal if you stop it suddenly, and there is dependence, but dependence alone does not addiction make, right? The list of criteria for addiction for a substance use disorder have to do with impairment and using despite consequences and having psychosocial loss of function in the main domains of life. And you know the list. And if these medicines make those things better and improve psychosocial function and reduce impairment under medical supervision, then I would think of the dependence or the withdrawal if you stop them suddenly as unfortunate side effects, for sure. So would I rather have methadone or buprenorphine that didn't make you sick if you stop them? Yeah, but it's a side effect that we can live with for their life-saving value. And just by way of analogy, and I'm trying to give you some language that you can help use to talk to parents, to talk to families, to talk to colleagues. Used by analogy, it's a crude analogy, but let me try it. There are people who are dependent on insulin for their diabetes, and if they stop their insulin, they become very sick. Does that mean they're addicted to their insulin? No, I don't think so. Again, we got to think about, well, what actually is the definition of addiction? You've heard the myth, it's not real recovery. Nonsense. It's as real as any recovery. It's one particular tool in the tool chest. Would we say that because people have to use tools like meetings or counseling or therapy, because they're not superheroes that can do it on themselves, that somehow that's not real recovery? No, we use the tools at hand. People say, I don't want to be on this forever. I didn't say you need to be on it forever. Let's just get you on it, and then let's stabilize your life, get you back the things you've lost, and then we can talk about getting off of it. For now, let's talk about getting on it. By the way, getting off of these medicines, although you'll hear this a lot, it's harder to get off buprenorphine than it is to get off fentanyl. It's hard. The problem typically is not that it's hard to get people off. It's hard to get people on and get them to stay on. That's the predominant problem. The side effects are unbearable. Well, any medicine, even a Tylenol, can have side effects. And yes, we have to try to work to ameliorate the side effects and match the correct medicine to the right person. And if one doesn't work, thank goodness we got 3, and there's lots of strategies. Most people tolerate at least one of these medicines. And then, oh, you doctors, you're just trying to make money off of me. Well, I hope that's not what we're doing. Again, I'm not going to show you all the research. We've got 70 years of research for MOUD in adults. We don't have as much research in youth, but the summary is that the evidence for buprenorphine is very clear. And that is the medicine of these 3 that is mostly used for adolescents and largely for young adults as well. Methadone is a good medicine and would be biologically, physiologically appropriate for anybody of any age. But as you know, methadone is only available in highly regulated, isolated specialty treatment programs that generally don't have developmentally specific welcoming features for young people. So whereas young adults 18 and up can certainly be in adult methadone programs, adolescents have a lot of barriers. And if any of you have worked in methadone, it's great treatment for adults, but you wouldn't necessarily bring your 15-year-old sister to a methadone program, not because the molecule is not a good one, but because the program isn't tailored for young people. So you can imagine an adolescent-specific methadone program, but there really aren't many or any. So we usually concentrate our efforts, and the medicines I'm going to be talking about today are mostly buprenorphine and extended-release naltrexone. There is also good evidence for extended-release naltrexone, but there's even less research in young people than for buprenorphine. And for both of these medicines, the outcomes are quite good. We don't know with as much evidence. We don't have the 70 years of evidence that we do in older adults. And what evidence we have so far, although good, is not quite as good as for older adults. I'll show you one example of that. But again, it's far better, far better than without medication. In terms of duration, longer is always better. It's tempting for people to think, oh, I've detoxed. Oh, I've been on this medicine for a week, a month. I'm fine now. I've learned my lesson. I've got this. First of all, the evidence is that when people stop medicine, they relapse. But there's also no evidence that we should arbitrarily limit the time. Most people should be on these for long amounts of time. And whereas some payers have restrictions in terms of duration, those have no evidence behind them. Good news in terms of use in adolescents and young adults, there's no suggestion so far that we have safety problems. Didn't have to be that way, right? The young developing brain and body, endocrine system, reproductive system, et cetera. Could there have been additional side effects in pediatric usage? And that could have been the case, but so far there's no evidence of that. That doesn't mean we won't discover something in 100 years, and that doesn't mean that there aren't side effects like there are for all medicines, including just Tylenol, but there's no evidence, no signal to date that there is specific side effects, worsening of side effects, or safety problems conferred by chronological age. MOUD should be first line in this population. There is no evidence for and no reason to suppose that we should give them a try with non-medication treatment first and see how it goes. And then if that doesn't work, second line, third line, fourth line, grudgingly use medications. Absolutely not. All the evidence says this is standard of care first line. And by the way, think of what fail first as a strategy would mean in OUD. Do we have to wait for somebody to have an overdose, a near fatal overdose, a fatal overdose, before we think we're going to move to definitive treatment? No, that doesn't make any sense. It should be the standard of care. That is supported by the American Academy of Pediatrics, by the American Society of Addiction Medicine, by the American Academy of Child and Adolescent Psychiatry. So there's broad clinical consensus. I'll show you just one piece of data. This is a large Medicaid claims review study looking at, I think, 2,000 or so across 13 different states. Young patients ages 13 to 22 who received a diagnosis of OUD and asked the question, how long did they stay in treatment over the course of a year based on whether they received MOUD or received other treatment that did not include MOUD. And in this survival curve, you can see that those that received medicine stayed in treatment over the duration of a year at much higher rates than those who did not receive medication. Well, some people ask, but wait a minute, if they get medication, maybe they'll stay in medication treatment, but then won't they not get other critical components of treatment? Counseling, therapy, groups, OP, IOP, other kinds of things. No, in fact, although I'm not showing you that data, the same study showed that patients that received medicine also stayed in behavioral treatment such as counseling and therapy longer too. So you can have your cake and eat it too. Unfortunately, in this study, even though these patients had received a diagnosis of OUD, only a quarter of them received medication. And that number for the under 18s was only 5%. So remember the point I made before about not everybody's gotten the memo. We know it works, we know it improves outcomes, but we have very alarmingly low rates of adoption. Here's another view of that. The last slide I showed you asked the question, well, if they get a diagnosis of OUD, will they get medicine? The answer was mostly not. Well, okay, maybe if they get a diagnosis, but certainly if they have an overdose, that should be a signal to the system, to the providers, to the programs that they need medicine. I mean, that's alarming, right? The biggest prediction of a fatal overdose is a past non-fatal overdose. Well, that turned out not to be the case either. We have here, of those young adults who were identified as having an overdose, only 1 in 3 got MOUD over the ensuing year. It's not that we do so great in older adults either. Look at the numbers for ages 26 to 45, but they're clearly worse in young adults. So we need to do better. So here's a little cartoon. If only it were that easy, right? All we need to do is just then put more buprenorphine in the water, right? If everybody gets buprenorphine, all will be solved. We can go home, declare victory. Well, if only, right? We unfortunately, it's not that simple. And buprenorphine's good, naltrexone's good, but it isn't the penicillin for opioid addiction. We don't have that. This is not something that is an illness that can be surgically cured. Like, here's the monkey on your back, no, the monkey in your brain anyway. We don't have that kind of surgical cure. And so let's look at the issue of what is different or specific to young people that makes it more difficult to treat them as a precursor to what we might do about that. And I'm going to offer you this clinical vignette. It's kind of a composite. Many of you will recognize some of the features, but you got some 17-year-old or 19 or 22 or 25. It's either a young man or a young woman. Doesn't make any difference. Typical story, onset of cannabis at age 13, might have been earlier. Beginning use of nasal or smoked Percocet at age 16. Depending on where you live, maybe that was Percocet. If you're where I live, it wasn't really Percocet. Progressing to daily use with withdrawal within 8 months, but that could be 4 months. That could be 2 months. Remember this rapid progression of opioids, and injection fentanyl 6 months later. And that progression from first use to daily injection fentanyl, within a year and a half is pretty typical. And contrast it, say, with the progression of alcohol use disorder. You would never see progression from first sip of beer to half a handle a day of vodka in a year and a half, right? That takes 30, 40 years. So again, the malignant progression of this advanced stage of SUD that is OUD. Anyway, this young person's had some treatment, been in residential treatment, inpatient treatment with detox a couple times, one time left against medical advice, one time stayed to the recommended completion date, but in both instances never had the recommended continuing care. It was kind of one and done or two and done, but not the enduring kind of treatment that we know is required. Went for outpatient buprenorphine treatment once, got a prescription for a month's supply, have a nice life, but didn't really take it all the time, sold half of it, continued to use fentanyl on top of it, not exactly a poster child for effective buprenorphine treatment. But now this young person is back, coming to me, coming to you, and says, Dr. Fishman, I really need help, knocking at the door of inpatient treatment. I'm sick, I'm miserable, I've been thrown out by my family, I've been dumped by my girlfriend, I'm in trouble with the law, you know, all the usual crisis troubles. And maybe I didn't do it right the last few times, but I've thought about the error of my ways. And this time I really mean it. I'll do anything you say. I'll stand upside down naked in the rain if that's what it takes. But you know, I'm kind of in a hurry. And I hear there's a good party Saturday night that I want to go to. And my girlfriend's waiting for me. So can we be done by Friday? And by the way, did I tell you I have a terrible anxiety disorder and I've tried everything and nothing works? The only thing that works is, you guessed it, Xanax. No, you can't talk to my Xanax doctor. No, you can't talk to my mom. What does she know? But other than that, I'm an open book. Let's get going. Now, I don't mean to dismiss or make fun of this young person's suffering. This person is clearly a person with a severe problem at great risk, including risk of overdose. But I throw it out there as the puzzle of a fairly typical interaction of treatment presentation to ask the question, well, what are we going to do to engage this person in treatment, to engage them in enduring treatment over the distance, right? It's got to be a marathon, not a sprint. And how do we do better? Why is it tougher for young people? What are some of the features of youth opioid treatment that are barriers to optimum outcomes? Lots of developmental issues. They're invincible, they're immature, they are not very motivated. Motivation, by the way, is not a fixed thing, right? It waxes and wanes and changes every nanosecond. That's true across the lifespan. It's especially true for young people. Remember, one of the things about motivation is that sometimes it has to do with consequences, and the consequences of addiction generally in young people are less salient than they are for older adults, in large part because young people don't have as many road miles on them. They haven't suffered as much, and their social roles are not demanding. They have fewer issues with mortgages and careers and marriages and child support and the necessities of social role that are sensitive to impairment. And they are even more motivated negatively by the burdens of treatment. It's not that we create very welcoming or exciting treatment for people at any point in the lifespan, but especially for young people, they got plenty of other things that they'd rather be doing, and treatment is lame-o, right? We have variable effectiveness of family leverage. So where is the family? How are they able to influence their young one? And I'm going to talk a lot about that. And the young people themselves tend to have a very characteristic pushback against their subjective sense of parental dependence and the over-intrusiveness of their families and the sense of restriction that they subjectively experience by their families. Now, that's developmentally normative. This is part of the 1 foot in childhood, 1 foot in adulthood that we expect and that we want from the normal maturational trajectory of adolescents and young adults. But it's especially salient here. You can't tell me what to do. What do mom and dad know about this? They don't understand. They just criticize and bully me, and on and on and on. And then you can't overemphasize the prominence of psychiatric and mental health comorbidity, which is very, very high in this population. So all of these things become barriers, right, to effective engagement. I'll show you some evidence of that. On the left is a secondary analysis of a data set from a famous addiction medication trial, which you may know about. It's the XSPOT trial. That was a randomized trial randomizing people either to extended release naltrexone or sublingual buprenorphine. That trial was comparing the effectiveness of those two medicines, and the punchline was that it's easier to get onto buprenorphine, but that once you get onto either of those medicines, you have about equivalent effectiveness to prevent relapse at 6 months. But this reanalysis of the data that we did was not about comparing the medicines. We pooled the medicines, looking at anybody on any of these medicines, and instead divided the populations into the older adults versus the young adults. And there were 450-ish total participants at the trial at multiple sites, and about 100 of those were young adults, ages 18 to 26. And these are the survival curves of non-relapse over 6 months. And you can see that the young adults did substantially worse than the older adults. And the numbers at the end of 6 months were 34% non-relapse in the young adults at 6 months versus 49% non-relapse in the older adults. And as I told you before, about 50% is the rough kind of number that we see again and again in adult addiction clinical trials outcomes in terms of retention and non-relapse at 6 months. But it was much worse for the young adults. Still much better than without medications. Don't get me wrong. Medicines, but that gap shows us that we need to do something different, something developmentally specific for young people. And on the right is another view of this. This is Medicaid claims data looking at retention, and you can see that buprenorphine retention is in a stepwise fashion worse for adolescents, a little better for young adults, and better for older adults. We still have lots of room for improvement in older adults, but young people do worse. So what do we do about that? So here's some of the journey that I've been on in terms of treatment development in our group in Maryland. One approach is youth specialty treatment. So this is a paper we published on 6-month results of a young adult specific opioid medication specific IOP. Now, let me tell you a bit about the population, because you have to take this data, which is, I'll explain to you in a minute, and it looks pretty good, but there's a bit of cherry picking here. These were young adults who'd been through rehab, completed rehab, got onto medicines, either buprenorphine or extended release naltrexone, their choice, said, I'm going to go to IOP and continue medicines. Not only did they say they were going to go to IOP, this data is only about those that showed up at IOP. So that's a very specifically motivated cohort of patients in the cascade of care. But taking that, we found that we had about 40% retention at 6 months with no substantial difference between buprenorphine and extended release naltrexone. So I take this as proof of concept that with a motivated subgroup of patients, you can do this work. You can treat young adults. You can give them medicines with high safety and high efficacy. You can mix the groups. It doesn't matter which medicines they take. You can create a milieu in which this is incorporated into a multimodal, multi-component, holistic counseling and therapy frame on their journey for recovery, including medicines. But what about upstream? Because not everybody goes to rehab, completes rehab, says they want to go to IOP, and goes to IOP. So a further step on my journey, we did a study where we looked at all comers to rehab, to inpatient SUD specialty care in the community, mostly Medicaid patients, about 300 of them with OUD, young people ages 15 to 21. And the first thing that was interesting is that even though our standard of care and our treatment culture, from the docs to the nurses to the counselors to the therapists, is that you ought to be on MOUD. It's standard of care. It's first line. It's what we recommend. Not everybody gets the memo, right? I keep saying that. A third of these folks received extended release naltrexone. A third of them received buprenorphine, again, patient and family choice. But over a third of them said, no, thanks, I don't want your stinking meds. And then what happened? So we followed them post-discharge. And remember, we're now following everybody who comes through inpatient, not just the highly motivated folks who finish inpatient or say they're going to go to IOP or show up at IOP. We're looking at what happens for 6 months after you get on a medicine. And those results are kind of crummy. Of those who selected extended release naltrexone, only 40% of them got a second dose, that is a first outpatient dose following an inpatient dose. And the average number of doses per person over 6 months was 1.3. Remember, for a monthly injection, you'd expect 6. 1.3 stinks, right? And it wasn't much better for buprenorphine. Of the 6 months of expected days of buprenorphine coverage, remember that number would be about 180, right? Only 57 days of buprenorphine coverage. So just because you persuade somebody to accept medication and give them a warm handoff and find a referral for them to go to continuing treatment that includes medication treatment doesn't mean they'll do it. And in fact, generally means they won't do it. Dropout and relapse is the rule, not the exception. And that's heartbreaking, isn't it? So what do we do about that? And one of the things that I think is a centerpiece of what we need to do for developmentally specific enhancement of youth treatment is focus on family involvement, family engagement, and harness the natural power of love, connection, persuasion, and leverage that families have. Most families. I mean, there are some families that are toxic, but on the most part, families have goodness in them and impact in them. And by the way, whatever you might think about, I wish they had better families, these are the families they've got. But there's barriers. We talk about addiction as a family disease, but in large part, and there are exceptions, but in large part, we pay lip service to that. And that's because there are historical barriers, and it's hard to do. It's hard enough just working with the individual patient in front of you. Now I've got to have all these other stakeholders. Remember, I mentioned that the young people themselves have this normative pushback against a sense of parental restriction and dependence. You can't tell me what to do. I'm invincible, etc. So there's that, but there's also that clinicians may not necessarily be trained in family engagement. They may feel like they don't have the competence or the comfort level. I didn't go to school to be a family therapist. And by the way, a lot of what I'm going to advocate does not require specialty training as a family therapist. It's just adding some skills and confidence to what every good counselor and therapist already knows how to do. But I'll talk about that in just a few minutes. Our field tends to focus on internal transformation, on internal motivation. You change because you want to. You've got to change when you're ready. And there's nothing wrong with internal motivation. That's great. But it often, maybe mostly, is not the first step, right? This myth of a blinding epiphany and a bolt of lightning and the scales falling from a person's eyes, and from then on, there's enduring motivation. Yeah, I wish. But mostly it's not like that, right? Mostly it's 3 steps forward and 2 steps back, or 2 steps forward and 3 steps back. And external motivation from external sources of leverage, and here I'm focusing on family, but it could be the criminal justice system, it could be other things where you find that your opportunities, doors are closed in your face, and you're persuaded. But we tend to focus on internal transformation, and I think to our detriment. When we do include families, which, as I say, is rare enough, but when we do, what's the message we usually give to families? We say, You've been enabling. You need to disengage. You need to let them hit bottom. You need to stop rescuing them. And I'm not saying that that isn't, in some cases, a relevant or useful bit of advice. Sometimes it is, although I mostly think that engagement is much more powerful than non-engagement. And I almost never advise non-engagement and let go, because you can't influence somebody if you disengage. But having said that, even if it's got a kernel of truth to it, what do you think the families hear when we say you're enabling? Whether it's what we intend or not, they hear it's your fault and that we're scolding them. That, of course, is not a very welcoming or encouraging message. Not likely to win friends and influence families. And lastly, I think we have an over-rigid concern with confidentiality. And for sure, confidentiality is central to what we do. So I'm not knocking confidentiality and the right to personal privacy in substance use disorder treatment. But I think we overdo it in an over-rigid way. And, you know, the cartoon of that is, you've probably seen this, maybe I'm exaggerating, but not by much. Mom drops the kid off at treatment. She's in the parking lot. She's in the waiting room. She's registered the kid for the treatment. She's paying for the treatment. She knows, right? She calls up and asks for the counselor and says, "How's my kid doing?" We can neither affirm nor deny that a person by that name is receiving treatment. You know, and again, maybe I'm overdoing it, but not by much. There's got to be a way where we can be more flexible in terms of including and empowering families. And I'm going to talk about that in terms of how to manage confidentiality. So what is it that unlocks the power of families? Well, the first thing is understanding their frustration and empathizing with their journey to date and their crisis. You know, and by the time they get to us or to you, families of youngsters with OUD are up to their ears in alligators, and they've tried everything. They haven't really tried everything, but they feel like they've tried everything, and they've tried a lot. And I've spent a lot of money, and I've done all this stuff, and I've bailed them out of jail, and they've stolen the car, and I've had to replace that, and I've had to send them to fancy pants rehabs and spend a lot of money on, you know, all of this stuff, and nothing works. I'm done. I'm finished. And they tend to migrate to these opposite poles of extremes. Either they're desperate for change and I'm just going to throw them out. I'm going to kill them. I'm going to cut their head off. I'm going for the nuclear option. I'm not standing for this anymore. And if they won't get fixed tomorrow, I'm done. Or on the other hand, there's nothing I can do. I'm helpless. I don't want to know about it. Don't ask, don't tell. Obviously, neither of those strategies at the polar opposites are effective. What we hope for is some balance in the middle that is consistent and persistent, that responds firmly but not punitively, that uses the power of leverage. But that's easy for me to say and not trivial for families in crisis to learn. Why families? Well, because both families and patients, but especially families, need a recipe. They don't know the secret sauce and the secret handshake of treatment. Got to lay it out for them. How does this work? What are the rules? What are the expectations? What are your responsibilities? What role can you have to play? Give them a job. I assure you, mom would like to be more effective, not just screaming. But she wasn't born knowing that. You got to give her a roadmap. And why families? Because they have core competence. They're going to be around long after we're not involved anymore as professionals. If I'm involved in the life of a patient for a few years, that's already the exception, but it's at the outside, right? Families are enduring. They have deep connections and love. They have special powers of persuasion and leverage that we just don't have. So they got juice. They may not know how much juice they have, but they always have more juice than they realize, but they need coaching. They need mobilization because they're so disheartened and demoralized. You know, I've tried everything. I've been beaten down. What can I do? We're all about the medicines. Medicines may help with the receptors, but medicines aren't generally going to be enough, especially if the patients aren't going to take the medicines. So one of the things I'm going to talk about is, what about families as champions for medication adherence? That could be a role, and I'll talk about that in a second. Well, if we encourage families and empower families, isn't that at the detriment of the maturation and the self-efficacy of the young people themselves? Don't we want to empower young people to take charge of their recovery? Well, yeah, we do. But why is it either or? I think that those are compatible. You can have both. By the way, most of these patients that we see, although we'd like to encourage them in their autonomy, are not very good at autonomy at the moment. When they walk into our offices, they are miserable and they don't know their bleep from a hole in the ground, right? I mean, they are confused, misdirected, don't know how to use healthcare resources, aren't motivated to make good decisions, are enslaved by drugs and by co-occurring disorders and that suffering. So they're not good at autonomy. We'll help them, but in the meantime, mom is probably a better guide to start with, or at least a collaborating co-guide, right? And by the way, we do that with every other kind of healthcare. If somebody that we love is having trouble navigating the healthcare system, we help them. Granny can't take her pills. We get her one of those pill cases and count them out for her and encourage her and call her up. If your loved one, your kid, your adult parent, your spouse needs care and it's complicated and is having trouble navigating the system or understanding the doctor, you go to the visit with them and you take notes and you ask questions and you support them and you guide them. But in substance use disorder, no. It's shameful, it's secretive, it's in the shadows. That's bad news, right? We ought to be able to involve families in an effective way that mirrors what we do, hopefully, in the rest of healthcare. Over the past 5-10 years, my group has developed a multi-component intervention that we call YOURS, Youth Opioid Recovery Support. Its linchpin is family involvement using some of the principles I've just described. We also use an assertive outreach approach. We use a low barrier delivery of MOUD, including home delivery and other kinds of things. And we use contingency management or motivational incentives to incentivize medication adherence with receipt of medications. I'm going to focus on the family involvement because that's one of the elements that is transportable, I believe. You know, doing medication home delivery and giving people prizes or rewards for medicines takes extra grant money. But involving families, I think you can layer on some of these principles without extra resources, just with a revision of focus and some extra competence and training. The idea of assertive treatment, though, just to make that point, is an old idea. I didn't make this up. It's well established for the treatment of lots of chronic illnesses in hard to reach populations in which medication adherence is a major barrier. So you've probably heard of assertive community treatment for schizophrenia and other chronic and persistent serious mental illness. We have directly observed therapies for medicines in tuberculosis and HIV. Anyway, these are well-known kinds of things. Why not apply them to OUD, right? So here's some of the stuff that we do with the family engagement components of YOURS. And I think these are things that anybody could do with a little effort without a whole lot of resources. First thing is that you understand that families don't know a lot about OUD. They certainly don't know a lot about the medications. So you got to teach them. And if they come with prejudices about medicines aren't real recovery or these are just poisons and blah, 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 well, you got to teach them. Just like if you were working in oncology, you wouldn't expect them to walk in the door knowing about the chemotherapy. That's up to us to teach and persuade. We start with the principle of a collaborative treatment agreement between the youth and the family member and the treatment team. And that's just routine. This is the way we do it. We're not singling you out because you're a baby, because we have to tell on you to your mommy because you can't take care of yourself. No, we always include families. Let's sit down. Let's figure it out. We come up with a written treatment agreement. Everybody signs it. It has all the whys and wherefores of what the care plan is going to be and how many times a week and what's going to happen if this happens or if that happens. And I'm not pretending it's a legal document or that it prevents people from straying from the plan, but it's a ritual of coming together in transparent communication. And speaking of communication, that's vital. It's negotiating the rules of the road up front, talking about confidentiality. Who's allowed to know what? Mom, I promise to tell you what you need to know, but I'm going to not tell you all the gory details. Young person, I'm going to keep your confidential information secret, especially if you tell me that certain things are off the table, except that if I need to call the cavalry because I think you're in trouble, I'm going to call the cavalry and we're going to collaborate on that. I'm never going to do it behind your back. I'm never going to do it unilaterally without your permission. But we are going to do it. It'd be better if you did it, and if I coached you to do it and role played you to do it, you did it in front of me and all of that, because that will help your communication skills. But mom's got to know because mom's going to help you. Family, what is your job here? What are you going to do to support attendance, to support progress, to support medication adherence? Are you going to know that they take the medicine because you directly observe daily buprenorphine under the tongue? Because you know when the shot of extended release naltrexone or extended release buprenorphine is due, and you're going to make sure they get to the clinic, and it's going to be circled in red on the calendar, and then you're going to find out did they actually get it. Well, he told me he went to the clinic today and got his shot. Yeah? Did you talk to us so that we can tell you if it's the truth or not? And then if he says, no, I'm not, what are you going to do about it? And what's the backup plan? And let's negotiate that up front before things get hairy, before there's the prospect of relapse and lying. Let's talk now about just in case things take a left turn or right turn. Oh, don't worry, Dr. Fishman. I'm committed to this. I've got this. You don't have to worry. I'm on track. Okay, that's fantastic. But just in case, what happens if you miss a session? What happens if you drop out? What happens if you stop taking the medicine? What happens if you miss a dose? What happens if you have a positive urine for fentanyl or for cannabis or for cocaine? Whatever it is, what would you like us to ask your parents to do, or what would you like your parents or other concerned significant others to do for you? Mom, in your family, how would you handle that crisis? And let's think it through now in advance. So those are some of the things. And as part of coaching the families, it's teaching them to pick their battles, to know their leverage, to know that they've got to negotiate and give to get. Why do I have to give something to make them do the right thing? Well, because it works. How's it going for you now? So you may not like it, but it's not going so well now. So maybe giving something and negotiating would be better. You can always fire me, but we can give it a try. And remember, this is a long game, as I say a lot, marathon, not a sprint. You got to keep your eye on the prize. So let's not get into battles about the 12 things at the bottom of the priority list that are getting your goat today. Let's pick one or two top priorities. We'll get to the other stuff. And just as a silly illustration, I can't tell you how many times I've had the families say to me, Dr. Fishman, can you get him to clean his room? And I say, well, you get to pick what's the priority for this week. Is it cleaning his room or is it injection fentanyl? I don't know, you choose. Maybe cleaning his room is for next Tuesday. And again, I'm exaggerating to make the point, but you get it. And it's a swirl. I understand that they want everything and they want what's best and they want him to get a job and they don't like the girlfriend or the boyfriend and they're mad about the tattoo or whatever, but let's stay focused on the prize. And even if there are slips and difficulties, that's part of the course of this illness. Don't give up. We keep going. We never give up. One of the things about this approach is that it's medication forward. And again, I'm not saying that medication is the only thing. It does happen to be very effective. And I think it drives, at least at the beginning, most of the effectiveness of treatment for OUD, and then other things filter on top as progress is made. But It also, this medication forward approach for family role and family engagement is helpful because it's understandable to families. It gives them a foothold or a handhold in climbing that very difficult mountain in a way that is recognizable. Just by analogy, you know, and this is especially true for moms. Sorry, all you dads, but it's the way it is. Every mom has had the experience of a 4-year-old kid with an earache and a fever who's cranky and squirming and miserable and doesn't want to take the pink medicine. That's Mom 101, right? What do you do with a truculent kid that is sick and can't take care of themselves and doesn't know how to traverse or utilize medical care? Now, for a 4-year-old, you can put them in a basket hold and squirt the medicine in. That's not as easy with a 190-pound 20-year-old. I get it. But the principle is similar. This is a sick person who doesn't understand, who's not in their right mind, who doesn't know how to navigate the health system. You be the mom. Now, it's not that trivial. It's not that easy. How to be the mom, how to do it, how to make it happen is where the devil is in the details and the rubber hits the road. But the concept people get. Here's just a poster child for our intervention. This happened to be a 23-year-old male, but it could be a teenager, it could be an older young adult. But the idea is this is a person who's been injecting heroin. Nowadays, this slide would say injecting fentanyl. It's an older slide. And they've had several inpatient detox admissions over several years. And each time, they've accepted a dose of medicine once before they left rehab, whether it's injectable naltrexone or injectable buprenorphine, doesn't matter. But despite the recommendation and the referral and the warm handoff, this person never continued in outpatient care, never came back for a second dose, inevitably relapsed, and was on the revolving door of back in rehab, back in detox. This time, we enroll them in a yours study, and we're doing this with research resources. So as I say, it's not necessarily trivial to implement all of the elements. But this time they're in yours, and grandma, with whom the kid lives, is the designated treatment significant other, TSO or CSO, concerned significant other. So she's our partner. And the team comes out, the nurse and the therapist come out to deliver the next dose of medicine 30 days after discharge. And he says, you know what? No, thank you. I've changed my mind. Like before, I don't want any more medicine. Now, I don't know if that's because he's already relapsed, or if he's planning to relapse, or he wants to keep his options open to use, or maybe he's still committed to abstinence, but he's invincible and says, I got this. I don't need medicines. It hurts when I get a shot. I don't want it. So we all try to persuade him, the nurse, the therapist, me, and no way. But grandma has got the juice, right? She's got the persuasion, the love, the connection, the authority. And she says, what are you talking about? No is not an option. You're getting that dang shot. And this guy does well, right? He gets 6 doses over 6 months, and he's our poster child. Now, not everybody does this well, but that's the idea. The idea is, how do you mobilize a family member to have a role to promote treatment and recovery, specifically using medication adherence in this instance as the thin edge of the wedge, as the tip of the spear, et cetera. We also use a lot of group texting communication. We get people to sign releases and include a family member or 2 family members and the kid and the therapist. And it's remarkable how much content you can get into a little text. I'm an old person, so that was a lesson for me. But my young therapists and research assistants taught me that, by the way, young people don't use phones anyway, right? So this is the only way you get to communicate with them. But it is amazingly amazing how compact and impactful it can be. So we can use it for monitoring. Hey, Brittany got her shot. hey, Dad, we're scheduled to get him back on the shot. Here is a conversation that reflects the idea of maintaining therapeutic optimism. Kid says, hey, I'm getting kicked out because you told my mom that I couldn't leave a urine. So yeah, I'm going to just have to stop the study. Or you can come leave a urine. I couldn't pee what I was supposed to do for 2 hours till I could. I'm bleeping homeless now. I'm just going to go have to live in the city in an abando. I'm still here. Come leave a urine. Don't use this as an excuse to relapse. Thanks for everything. Goodbye, cruel world. Okay, I'm coming up to leave a urine, et cetera, et cetera. So we just keep at it. You know, don't take no for an answer. Therapeutic optimism, trying to get to yes. By the way, that principle of getting to yes is core to the idea of confidentiality and to communication rules of the road. You might imagine, and I did when we first started this work, that there'd be people who'd say, no, I'm not agreeing to include my families. And yes, it happens once in a while, but it's once in a blue moon. You can almost always get to yes. Maybe not today, but we don't have to negotiate that today. We keep at it, and eventually most people will be grateful to include collaborating family members. One of the things you can do to win their collaboration is to show them that you can run interference. What if we're in a group session and I tell mom, whoa, that's a little harsh, Mrs. Jones. Maybe if you said it this way, and they look at me and say, whoa, you said that to my mom? Right, that earns you a little bit of credibility. Now you have to, work that in advance and work both sides of the room in a way that both sides see you as their ally, but it can be done with a little finesse. Here's an example of family empowerment. Nurse and therapist go out to the house to deliver a dose, look for a private part of the house. Excuse us, Mom. Mom wants to tail along and witness the shot. Patient says, Mom, you can't be in here while I'm getting the shot. And those of you who know, by the way, for Vivitrol, you're dropping drawers. It's a gluteal injection. And for extended release buprenorphine Sublocade, it's an abdominal injection. So you're pulling up your shirt. So, it's a private healthcare procedure. And the therapist says, ma'am, I think it's best if you stay out here and provide us some privacy. And the mom says, what, are you kidding me? Of course I'm watching, and I'm not leaving this room till I see that medicine go in you. Now, I'm not necessarily endorsing mom's behavior. Maybe she's being a little over-intrusive. Maybe she's a little suspicious. Maybe it's appropriate. I don't know. Hopefully, over time, we can get her to be more trusting. But I use it as an illustration of giving mom a job, giving her a role, and empowering her to feel like, not just feel, to be effective to transform change in a meaningful way. Anyway, let me just show you some of the results. In our first randomized trial, small pilot, we compared the yours intervention to usual care, treatment as usual. And in this histogram, you can see that people in the intervention got many more doses, on average 4.3 compared to less than 1 in usual care. Maybe not so shocking that if you do all these things, involve families, deliver the doses at home, keep in touch assertively, pay them to get the dose. Maybe it's not so shocking that they'll get more, but it's a nice proof of concept. And 44% of the yours patients received all the doses in this trial compared to 0% in the usual care. And we replicated it. The first study we did was with extended release naltrexone only because there wasn't extended release buprenorphine. Later on, we did it again with choice of extended release buprenorphine or extended release naltrexone and got essentially the same results. And here's the non-relapse survival curve showing that we get much better non-relapse with this intervention than we do in usual care. Unfortunately, as much as it's a assertion of the effectiveness of this treatment, it's perhaps just as much or even more a reflection on the ineffectiveness of usual care. You can see here that, the relapse rate in usual care was 95%. So that's a problem. And although we get maybe 45 or 50% non-relapse in yours, that's still plenty of room for improvement. So we're working on it. And we've added some things, medication choice, obviously. Telehealth was the lemonade that we got from the lemons of the pandemic. I'm sure all of you have too. We started delivering doses in a mobile van as an infection control kind of intervention, not to be in people's houses where we didn't know, who had COVID and who didn't. And we started a telehealth support group where families and other concerned significant others do kind of peer-to-peer support and help with each other, benefiting from each other's lived experience. So, that's a big plus. And so we're out in the field with another larger NIDA-funded randomized trial. This time we hope to get 120. And our interim analysis is essentially the same. It's looking good. And we looked at the two age groups, the younger young adults and the older young adults, and found that looks like it's more potent for the younger folks. Maybe that's a reflection of their increased responsiveness to family. And that led us to the idea we should try it in adolescents. And that makes sense, right? Adolescents will probably be even more embedded in their families and even more likely to be responsive to family involvement. So we just this month have started a small pilot trial with adolescents and a small pilot trial using sublingual buprenorphine. We've primarily been using extended release MOUD because the verifiability of receiving the dose is easier. It's a once-a-month event. How are we going to make sure that they're really taking the sublingual buprenorphine? What we're trying to do is Monday through Friday, 5-minute Zoom, take it while you're on camera. I don't know if that's going to work or not, so stay tuned. It's what we're trying for the moment. And then, giving them motivational incentives, $2 at a time every time we see you take it. I wanted to point out, so there's yours for you. And let me spend just a little time talking about some other potential innovative approaches that I recommend to contribute to improving outcomes for youth. One is just telehealth broadly. And I'm sure you guys are doing this, using telehealth. It's such a great tool. It's not maybe as good as in person for some people, but it sure does reduce barriers and improve access for a large number of people. And I want to show you these illustrations of how telehealth can be very family impactful. So what about a 21-year-old in rehab who has done poorly in the past with buprenorphine, and mom is kind of against buprenorphine? He's tried it, it doesn't work, he sells it, he gets high on top of it, he doesn't take it. Well, let's talk to mom about trying something different. Maybe mom doesn't know about extended release buprenorphine, and let's just talk to her about it. And the nice thing about that is you don't have to schedule a big family session or have her have to fight traffic to come in, all that. She's got 3 jobs and 5 other children. Just get her on Zoom or on the telephone, but Zoom's better, right? Or what about, I'm seeing a 17-year-old young man by Zoom for outpatient, and I'm treating him with sublingual buprenorphine, but his parents are encouraging him to get off of it because it's just replacing one addiction for another. And he's feeling the heat, the pressure. He doesn't know what to do. So I can say, hey, is mom at home? And if I'm lucky enough that the answer is yes, I can say, well, just go get her. Let's talk to her. Again, spontaneously, not having to do a lot of scheduling to have her drive in and all that kind of stuff. And if you can, well, then you've got an important conversation. Or a young adult in relapse who has been couch surfing and living in his car, maybe under bridges, I don't know. And mom wants to get him to return to treatment, but she doesn't know how to do that. He wants to go home, but the family's understandably reluctant. There's young kids in the house, or he steals stuff, or, you can't be using in my household. It's not safe. Well, let's get everybody on a 3-way Zoom and talk about negotiating the terms of return home. It's not no, it's yes, but we'd love to have you home, but first you have to do X, Y, Z. Well, I don't want to do X, Y, Z, but we love you and you want to come home, so try X, Y, Z. treatment, medicine, whatever. But being able to negotiate that without everybody having to wait till next Thursday and fight traffic and et cetera. Another innovative intervention that's got some traction is migrating youth MOUD into youth-serving primary care, so family medicine or pediatrics. And we sometimes talk about this as a hub and spoke model in which primary care folks, practices, clinics, as spokes can be supported by a specialty center as a hub, because pediatricians and family care docs might be reluctant. I don't know how to do buprenorphine. I don't necessarily know how to do opioid addiction. I'm uncomfortable. What's going to happen if I put up a sign that says buprenorphine within? Am I going to have a line around the block? And then I'm going to have a bunch of these patients in the waiting room, and that's going to be a problem for my families. And the answer to that is, no. We're not asking you to be specialists. We're not asking you to recruit other opioid addicted individuals from around the region, from around the state, from around the 10-state area. We're saying that you already have these young people in your practice, whether you know it or not. So what can you do to broaden your holistic care and get more tools in your tool chest, just like you would with any other subspecialty of medicine, to bring it into your practice? But let us hold your hand. Let us teach you how to do it. Let us get on the phone while you're seeing the patient. Let us advise you. Let us backstop you if it's high severity and you need referral for a consultation with a specialist. And that will get people more comfortable. And by the way, when they've done one, they realize how easy it is, and there is no line around the block. So this has been a somewhat successful model. It's been championed by my colleague Sharon Levy up in Boston, but also reproduced elsewhere. And the idea being that if you bring this technology into primary care, it also has the other advantage of getting primary care folks more savvy and more aware about other substances. Because remember, OUD is going to be relatively rare compared to nicotine, alcohol, and cannabis. And although there may not be good medicines for nicotine, alcohol, and cannabis, there are some. Just getting them to be comfortable to talk to patients and families about substances in general is practice transforming and life transforming for the families and patients. Another thing that we've dabbled in, and I've seen other people do, is youth-specific recovery housing. Lots of places have recovery houses as part of the continuum of care. They tend to be not so much professionalized as supported by people in recovery with self-monitoring and out a lot of staff. Young adults have trouble in those houses, both because they don't get enough supervision and they get into mischief, but also because they get into mischief and they get kicked out because they don't follow the rules. They bring their girlfriend over, they don't make curfew, whatever. And so the idea that you could stand up youth-specific, developmentally informed recovery housing that is both a little bit staff heavier with some supervision, but also is flexible with the expectation that youth will get up to mischief and that maybe you don't have to kick them out over it, and embed it in the full continuum of care so that even if you have to kick them out because you want to protect the rest of the housemates from access to their drugs when they relapse, that you don't just street them, you bring them back into treatment, outpatient, inpatient, whatever. And this looks successful. We have a special grant from our state. I'm not sure that you could do it without those resources, but I do think that there's a future to it. You may have heard of the intervention called CRAFT. CRAFT's been around for a while. It was originally invented to treat the population of wives of adult male non-patients, out of treatment individuals with alcohol use disorder, to help leverage the persuasive power of a family member to promote treatment. But this can be adapted, just as I've been talking about, to the families of young people with OUD. And we are doing something about that. We just got funding the past several months for a study that we call BOND, Building Opioid Recovery Support Networks to Engage and Retain Young Adults in Medication for OUD. I forgot how we got BOND out of that. I don't know, but everybody needs a fancy acronym. But the idea is that whereas we've had some good experience and success engaging families to help young adults and adolescents who are treatment presenting, what about out of treatment youth? So this goes upstream to try to target and engage concerned significant others, loved ones of people who are out of treatment, young adults with OUD. I've got a kid, I know they need treatment, but I can't get them into treatment. They won't go to treatment. And this will work with the CSO, the concerned significant other, the family member, is the primary target of the intervention, to use family coaching to help them get that person into treatment. So here's our little poster for that. We'll see if this is any good. We got to test it. Part of the issue is, where do you find these families? How do you recruit them? How do you get the word out that there can be help? So we've got flyers and other kinds of things. So we'll have to see. Anyway, I want us to have a few minutes for questions and answer, but I just want to conclude with this, that we have lots of tools. Some are existing, some are emerging, but unfortunately, those tools don't have the uptake that we wish they would. And all of the research and all of the clinical consensus supports medication-forward treatment across the lifespan. And that goes for young people, that goes for young adults, it goes for adolescents. So we need to do better. Even for those, as I've said, who do initiate medicines, we need to do better in terms of retention and going the long haul, because unfortunately, dropout is the rule rather than the exception. So what can we do that is developmentally informed? I hope I've given you some examples of those kinds of things. I wish we could do brain transplants, like the little sign on the right? The hypothetical miracle cure. But in a way, we kind of can, because if you keep them alive long enough, they mostly do grow up. And so I like to be optimistic about that hopeful message of hanging in there with them, despite their foibles, despite their sometimes knuckleheadedness, that if you keep working with them and engage with them and learn how to form the alliance with both them and their families, even if they drop out, maybe they'll drop back in. And so it's the long game, it's the marathon, not the sprint. So I love the phrase therapeutic optimism. We want to give people the message that there's always hope.
So I am pleased to announce our winners of the System of Care Champion Awards. The first one is Deputy Chief Justice Deborah Hembry Lambert. Justice Lambert has been the driver of the Kentucky Judicial Commission on Mental Health. That commission has convened multiple partners across the entire state with the real goal of fixing and addressing issues in the system. So finding them, fixing them, and really has already produced many significant changes across the Commonwealth. So on behalf of her leadership for that, we are very pleased to announce Justice Lambert as one of the winners today. And the formal physical awards will be mailed to all of these folks. So, but we do want to give them they're doing their shout outs here. The second one is Miss Kivy Figs. Kivy is the Juvenile Trial Court Program Coordinator with Fayette County Schools. And for those of you who aren't aware, the Juvenile Treatment Court is the first ever in Kentucky. So that was created by a couple of judges, and Kivy has been an integral part of that entire process. Getting so far 7 youth have graduated from the court program. She's really been fostering lots of external partnerships and community integration, though, to really wrap around services around these youth and really start that process of teaching us how to do that moving forward, how to see a youth and their needs in the juvenile treatment process as being really important, and them still being, of value, And these youth report feeling cared for and nurtured, and that they're supported in moving forward, away from the treatment system after they come through the court. And that is a lot of that is due to Miss Figs. So definitely happy to give her the system of care thing. And I know we're going to continue learning from her in the future here as we change the system. And then the next one is Bridget Fulkerson. Bridget is a parent representative with the Lincoln Trail RIAC, that's RIAC for ASL. She runs an autism support group in Washington County. She's also been a vocal advocate at the state and local level for autism services and treatment, parity of autism services, and lots of other things. She's really been an inspiration to other family members as well. And she's actually helped self-advocates as well. So she's been a real piece of support in the autism community, really working from that and changing the world just a little bit at a time for those folks. So we really want to thank her for her work and her system impact as well. And then we have one that we had one person who was nominated who we couldn't really give an award to because these awards really come from the Department of Behavioral Health, but MHA wanted to make sure we gave a shout out to Lee Taylor. She's on today. She has been the leader of this entire series for 8 years. So she is the herder of cats, the contractor, the organizer, the tech support, all those things for the System of Care Academy for these eight of the last 10 years that we've been around. So felt like it was worth giving her a special shout out. And so thank you, Lee, for all of your dedication and your work.